Good afternoon, everybody. I would like to welcome Commissioner Auerbach. Mayor Flanagan unfortunately could not make it today. He's in Washington, D.C. So he's asked me to welcome the Commissioner.
Thank you, Dr. Valencourt, and welcome everyone. It's a pleasure to welcome you to Bristol Community College. Many of you have been here before. We try to have a better day for you, but it's a pretty good view in any event once we have a fun. So it's my pleasure to introduce to you the Commissioner, John M. Auerbach.
Thank you very much. Thank you for hosting us here. It is nice to come back to Bristol Community College. It's nice to be back in Fall River. So hello, everybody. Let's see. Here I am. This is, by the way, this is what the Fall River Department of the Future is going to look like. Henry, where's Henry? What do you think? Your window right there on top? So maybe someday. So the topic I am going to talk a little bit about what are the current challenges we're facing and what are the opportunities right at the moment, and then maybe suggest some of the changes that we need to make in terms of how we respond as a state health department, as a local health department, maybe some community agencies too. And then share with you on an up note at the end of my talk some of the positive things that have occurred in spite of the fact that it's been a few really tough years in the economy. This is going to be very informal, so in the middle of my speaking, if there's something you want to say or a question you want to ask, just raise your hand. And, so let me mention. Let me see, I'm going to have to do this. I'm going to turn sideways so that I can actually see what's behind me. This is some of the situations that have framed the circumstances that we face now. In Massachusetts, healthcare reform has largely been successful, and that's changed the landscape of the way that health is sought in the state. Right now, we're about to begin a very significant additional change, which has to do with reshaping the way that health care services are paid for, this notion of payment reform. And while the focus on payment reform is really on clinical care, there's lots of opportunities for people who do preventive work and public health work to also be involved in the discussion about payment reform and to consider whether there's an opportunity for us to be better linked to clinical care and maybe even able to generate some new revenue sources. But we're still dealing with budget cuts, and so budget cuts are obviously on everybody's mind, local, state, and federal cuts. But at the same time, while we still have the federal Affordable Care Act, the health care reform bill that was passed nationally, we've got some very good opportunities. Not just the opportunities that come from expanded access to health care that we've had in Massachusetts, but other parts of the country will have, but also that within the federal health care reform bill, there's the creation of something called the Prevention and Public Health Trust, and that sets aside billions of dollars, the intent of which is to get money out to local communities and states in order to support preventive activities so that people are less likely to become ill, less likely to need the more expensive and complicated healthcare services. And we've been able to apply for money against that fund and bring millions of dollars into the state. Now, I'll explain what some of those are in just a bit. I guess just a reminder about the success of healthcare reform. 98% of the population has insurance now, and we were worried about, in the beginning, 5 years ago, you may remember, we all were worried, are there enough primary care doctors to go around? The surveys are indicating pretty good, because when we survey folks, 91% of the people say, I have a primary care doctor, and I've seen that doctor in the last year. That's significantly higher than any other state. So it means that people not only have insurance, but they have a doctor, someone they call their primary care doctor, and they can say, I've seen that person in the last year. From from a public health perspective, we care more about the benefits that might come from health insurance than simply having health insurance. You know, I feel like too often the debate ends up sounding like it's, do you have insurance or not? When really the discussion should be, what's the best way of promoting the health of the population? The assumption is, if you have access to health care insurance, you're going to be healthier. You're going to get better care. And we want to measure that. So we've looked at a variety of different ways of seeing, is the assumption that if you have a health insurance card, you'll be healthier an accurate one? We've seen some good indications of that. I won't go through a long list of that, but I'll mention some that we've seen. This showed that we saw a significant drop in cigarette smoking when we expanded insurance options to folks. The reason was, first year, 400,000 more people got health insurance in healthcare reform. And by and large, our surveys indicated those 400,000 in that year got a physical. And part of a physical would be reviewing your risk behaviors, doctor talking to you saying you smoke, you should give up smoking, and talking to the patients about maybe nicotine replacement therapy or linking up to smoking cessation groups. All the data indicate a doctor offering you that, you know, for a number of people is very successful. So that green bar that you see jump up there, that's the first year of healthcare reform. It represents a dramatic increase in the number of people who gave up smoking that year, and we've seen that sustained. So we're among the lowest states in terms of cigarette smoking now, in part as we survey people as they've had access to assistance in giving up smoking, like nicotine replacement. This chart also shows the increase in terms of both screening and treatment that follow healthcare reform. And it shows, among other things, I'll take a dramatic one, that we had an 8% of the population that should have a colonoscopy, an additional 8% received a colonoscopy right after healthcare reform. Again, it made sense. If you're age appropriate for colonoscopy, you're more likely to get one if you have insurance. If you're only going to the doctor when you're sick or to the emergency room when you need it, no one's going to refer you to get a colonoscopy, and you're not going to pay out of pocket for something that you don't view as life-threatening. But in those 400,000 people, of those, many of them needed to get colonoscopy, hadn't had it done. And colonoscopies are not only screening, but they also can be preventive. You can prevent getting colon cancer if you have a colonoscopy and it identifies precancerous nodules and you get treated for that. So it's a very important indication of the kind of care. We expect to see colon cancer rates going down, some anti-childhood obesity grants, and we've gotten money to do some restructuring in the states. Among the things that's done is it's given money to create incentives for the local cities and towns throughout the state to work voluntarily in collaborative districts or regions. So for the first time, we can try to create a more rational way of providing public health services to the residents than assuming that each local community can really offer all of the different needs of the community. Having groups, having cities and towns work together allows them to share their resources and provide a wider range of activities. This was new money to support that and to create incentives to work together. So we've been a laboratory for the rest of the country in terms of healthcare reform. We're now about to become a laboratory for the rest of the country in terms of payment reform. And this is a big new step. The idea here is to move us away from the system that exists now, which pays for services on what's called a fee-for-service basis. I'm having to look really handsome now. Funny thing. I look good. So fee-for-service basis basically means you only get paid as a clinician if you provide a unit of service, a visit, a test, etc. The new idea behind the reimbursement payment reform is instead of paying for more treatment, pay for people to be healthier. Pay for incentives for clinicians to organize care so that the priority becomes not volume, but good outcomes, and allow greater creativity among providers about how best to do that. The way the proposal, which the governor has made, would be to, as a state, make our most common way of reimbursing shift from a bill goes in every time a unit of service is provided to paying a global fee for each of us with clear outcomes, quality outcomes for the providers that have to be met, showing that patients are staying healthy, that high quality care is being provided. The devil's in the details about how you do that, but the idea is to create the right incentives, and that's what this very significant debate is. Traditional, when you hear prevention sometimes, and when people are talking about it, what they really mean is a physical, or they mean getting your vaccines. That's prevention, but it's a kind of prevention. It's the kind of prevention you get in a clinical setting from a doctor or a nurse, and insurance pays for that. We want to make sure that we not only continue that, but we increase the percentages so that we see more people that need to get colonoscopies and mammography screening and vaccines getting that in a clinical office by structuring that new payment system so the quality measures that must be met are very high screening rates and prevention messages about not smoking too. But there are a couple of other types of prevention. Did I get that right? No, that's one. The one type of prevention is kind of a gray zone, which sometimes involves work with a clinical team and sometimes works in a community setting. And these are activities like the activities that community health workers are involved in. We know from the evidence of a number of studies that community health workers can be very helpful as members of a clinical team in following up with patients to make sure that the information that they were given by a doctor is fully understood, to make sure that patients are able to become compliant with anything from taking their medications in an appropriate way to trying to exercise or eat better. Right now, community health workers, though, aren't reimbursed. We, by insurance, what we think is with the new way of thinking about payment reform, we may be able to make it more routine that community health workers should be part of that global payment reimbursement. And that would provide a firm funding source for community health workers. I think we'd see more routinely that we would be incorporating them into clinical practice. Other things that might be included there and paid for by insurance now might be such things as training for patients who've just been diagnosed with a chronic disease about the chronic disease self-management. There are multiple training courses that have been shown to be very effective that someone, say, who's just been diagnosed with diabetes would go and learn about controlling their own illness, taking control of their health. We want to make sure that everyone has an opportunity to do that. Having a funding source helps. So those are the kind of things that we need to pay attention to and make sure that if we have a chance, we get those incorporated into the payment reform. And then there's the basic type of prevention, that's the third type, and that's creating conditions in people's lives so that they eat well, they exercise, they don't smoke, not because they've been told by the doctor they must do that, but because there are conditions that are created in their lives that just make the healthier behavior the natural one, the one that they can do without having to decide that, oh, I'm going to stop that bad behavior. What do those include? Well, those include things like ensuring that the foods that are served in schools are healthy. Not that there's a healthy option and a child could decide to select that one, but that the only kinds of foods that are served are healthy, so that you don't have to worry about will they choose this one or that one. That exercise is easier, and exercise includes things like making sure we're designing our communities so that it's very easy to walk to school for kids, or if you want to walk to the store, you don't have to instead get into your car and drive, because there's really no way to cross that 6-lane highway to get to the part of town where the store is. That means rethinking many different aspects of the way that communities are organized in order to make the healthier behavior the more natural behavior. That's part of this. Can we link that up and get parts of it paid for with payment reform? Maybe. We have to make the case that having certain behaviors, certain conditions established will lower the cost of treatment treating patients because the patients will be healthier, and therefore the providers getting that global payment fee will say, this is in our interest to include those as well. But that's a little bit in the future, right? So we have to work on that, but we've got a moment here we might as well take advantage of. So if we are taking advantage of these new opportunities, and there are many new opportunities, and also adjusting to some of the new challenges, what are the specific skills we think we need? And I'm just going to highlight a few of these. One of the things we need to do is we need to decide where is our work best focused. For many of us, for years and years and years, we operated at the top of this pyramid, one-on-one, trying to convince people that they should improve their health by not smoking, by exercising well, etc. So that's important to do, but that's resource intensive and you affect one person. We need to do that. That's very important to continue. But as you move down this pyramid, you're able to reach more and more people by operating at a different level. And so what we think is, it may be that whenever we can, what we should be doing is operating at this level, which is not on a one-to-one basis, but doing some of those policy changes that I was mentioning earlier. So what does it mean if we operate at that level? Well, one of the things it would mean is that we would try to incorporate thinking about health in all policy matters, not just those related to healthcare delivery or public health. It means that we have to get better at working with our colleagues in our communities that say are the transportation specialists, or the parks and recreation specialists, or the safety specialists, and engage in the discussion about whether or not there are policies that can be made by those other domains that may have a positive impact on health. So I'll give you an example. We have begun working with the transportation department for the state, where we encourage that department to incorporate into any of its major transportation planning some prioritization, not just of automobiles, but of pedestrian, walking, and biking. And not only that, that we ask them to incorporate in some thoughtfulness about whether the design of a major transportation unit will create ways of encouraging people to walk and get around, or whether it will divide communities in half, so some of that, what I was mentioning earlier, of you can't get from this side of town to that side of town without a car, we'll see less of that. Cheryl Bartlett, raise your hand here in the front row. So Cheryl Bartlett is the director of our Bureau of Community Health and Prevention. So her bureau oversees all of the prevention and chronic disease programs. Cheryl has assigned a person who works for her to go to the state transportation meetings. That person went for maybe a year and a half to the transportation meetings, where frankly nobody really wanted our help. You know, it's not like we show up and they say, oh great, we want to add cost and delays by including your priorities in our priorities. So what you had to do is basically go there, get to know people, understand their culture, their pressures, their priorities, and build trust. And understand when there was an opportunity to suggest that there were ways of incorporating components of consideration of health into their planning process that would be mindful of their fear about cost and delays. And it's worked. So we now have an agreement that on these major projects, there'll be something called a health impact assessment that we help them with that will try to point out ways of considering the health impact in their plan and making some adjustments that they think they can do relatively easily without this, throwing the whole thing out the window. And so far we've been making progress there. But it took a new way of thinking. Instead of our sort of talking about people need to walk and why aren't you walking more, and then people live in communities where it's just not possible to walk easily, we want to also work with the policymakers. And that can happen very easily at the local level. So a second area that we think people need to do more work with in my field, in public health field, is understanding how to make linkages to the clinical providers, the hospitals, the health centers, the clinical practices, and build the connections that are necessary. I've talked repeatedly to doctors and clinicians who have expressed their frustration at having patients with serious chronic illnesses who aren't adapting their behaviors to reduce their symptoms. And what they have, often when those folks are in a room with public health people who are working in the communities where their patients live, the clinicians will say, can you do something about the fact that, I've got this patient with diabetes, I'm saying, you should be eating healthier foods, but she tells me there's no store in her neighborhood that sells fresh fruits and vegetables, or there are other obstacles to her doing that. Is there a way of your creating a different condition in her neighborhood where that might change? And we're building those bridges where if there's an increase in diabetes in a particular neighborhood, we want to hear about it from the clinical practices and see whether we can work on the prevention side to try to create conditions which may make it easier for patients to reduce their symptoms. Let's skip over that. So new skills I think we need to have. One of the new skills we think we all need to have is understanding what the potential and challenges are in terms of the move to the internet as a critical way that people are gaining information, having their medical information transmitted and collected. We've got to get better at communicating with social media, from Twitter to blogging to developing videos that go up like that on websites. And we have to understand what the potential is with electronic medical records, maybe giving us better real-time understanding about what are some of the health problems in a community. Another thing we need is we need to be better at making the economic case for prevention. I've spent the last 5 years going to meetings with insurers where I say things that probably most people in this audience would agree with, like I say, smoking is bad for you, and you should be offering a benefit of nicotine replacement therapy and counseling. And no kidding, this is what one insurer said, which was characteristic of what I hear non-infrequently. She said, I agree with you. Clearly nobody should be smoking. It's bad for their health. But if they stop smoking now, the health benefits of that we're going to see 15 years from now when the person doesn't get lung cancer. And by then the patient's going to be on Medicare. I'm not going to get the savings. Now, at first I was taken aback, but the truth is the insurers are evaluated on a year-to-year basis about controlling premium growth. So they're worried. The truth is they are worried about being able to keep the premiums low. We spent some time looking at whether we could make the case that there were short-term savings from giving up smoking that might make the economic argument to the insurers that they'll see it. And we found them. We didn't know if we'd find them, but we pulled the Medicaid records, we did the analysis. What we found was when someone has access to nicotine replacement therapy and stops smoking, within an 18-month period, you have statistically significant reductions in the population of people that applies to, in terms of heart attacks and visits to the emergency room for respiratory illness. And you can calculate how much money you save in 18 months. And the insurers listened to that, because that wasn't 15 years away. That, we don't have among us people who sit around and calculate that, right? That's a profession, health economists, who are able to do that. But we need to have access to those skills so that we can make the economic argument in favor of beneficial prevention measures, and that they're not just saving lives, but they're saving money with a return on investment in a relatively short time. So, and again, new skills we need. We also need to take a critical eye to what we do with grant money or with government funding versus insurance. And at the Department of Public Health now, we're looking at these things. We're deciding whether they're things we've always done that we don't need to do anymore, because now everybody has health insurance, or 98% does, and that therefore the system was set up when people didn't have insurance and we could stop doing it. And so there's some things we're phasing out because people can access those, have it paid for with insurance. We don't need to pay for it with precious public health dollars that we might be able to switch to. I want to end, let me see if I can end by doing this right. Okay. So here's some good news stories as I end my talk. These are some things where we've seen some promising changes. Mass in Motion is our anti-obesity, anti-chronic disease program, and it started 5 years ago without a penny. And the idea was identify the issue, it's a big problem, now what do we do? And we looked for the programs that there was evidence they were effective, and then we looked for money, and this was like a piece, penny by penny effort. We had 5 foundations that kicked in money initially, and we could fund 14 communities. We just in the last 9 months have gotten 3 big grants from the federal government, and we now have 53 communities that get grants out of the 351. That's a lot of communities, and it includes some of the higher population communities like Fall River, New Bedford, Boston, Worcester, Springfield. But so we reached a large segment of the population, and we've gone from 0 money to $5 million a year on Mass in Motion, and we're seeing results already in terms of some of those trends around obesity. Here's to just give you some sense of this. Any community that's on the map that has a color on it is a Mass in Motion community now. Our goal is everybody, but we're making progress. We've also passed some regulations. Not everybody loves regulations, but we think these ones are really important in terms of promoting health. We now have the healthiest a la carte or competitive food school nutrition guidelines in the country. This is not there are 2 different general categories of food in schools. What the federal government does is determined. They're improving their standards too. This is what's decided at the state level, and it's the a la carte items, the vending machines, et cetera, et cetera. So starting in September, the friolators come out of the schools. Every school. And we really move, and schools will have much more fresh fruits and vegetables, low-fat options. We're moving to that. What I was saying is the default, which is parents should not have to worry about what their kids are eating when they go to school. We have some work to do to make sure that the foods are delicious, because we want them to be tasty and not just, foods the kids want to eat, but that's a problem now anyway. And we've worked recently on the issues of head injury, which has been a growing problem we've been monitoring of not an insignificant number of kids who report to us that they've had significant head injuries. I just looked at the Massachusetts survey that we're about to publish on this, and it showed about 1 in 5 teenagers in high school have said they've had a head injury that they think has had an impact on them for a short period of time at least. And these are head injuries, by and large, that are in sports. And so there we have the opportunity. We've learned from the professionals as well as high school students. There are things we can do, and we can just prevent these injuries in kids, and they're important to do. So those regulations are going to be going into effect. And we want to make sure that we've got the ability of we want the residents of the state to have access to the full range of public health programs that will keep them healthy. Those are very hard to provide when there's a small number of people, often one person in the town who's the public health person. The requirements in Massachusetts to provide a long list of public health activities is the same for a community with population of 2,000 or 3,000 as it is for the city of Boston. But guess which one of those 2 has the capacity to offer those services? Boston has 1,200 employees. That person, that is a smaller community, may have a full-time person if they're lucky. Sometimes they don't have a full-time person. So what we want to do is create some uniformity in terms of what the expectations of the public can be across the state. And one way to do that is encourage cities and towns to cooperate with each other, pool their resources, think about specialization, and think about working as efficiently and effectively as they can. We've had some success in moving in that direction. Where's Jeff Wilkinson? Jeff Wilkinson is raising his hand now, works at the Department of Public Health for the last 5 years. And before that, when he wasn't at the department, worked on this issue and has had great partnership with those of you who were here from local health and thinking creatively about how do we do this. Jeff spearheaded an effort that brought in $1 million a year, again from that Affordable Care Act, Public Health and Prevention Trust, and that is providing financial incentives for communities to come together voluntarily and begin to work as districts, where they share resources, and so far we're hearing great feedback from the communities that have been able to do that. Nobody's forcing them to do this, it's voluntary, and there are incentives like some additional funding, some additional training and technical assistance, and new tools. And the tools include electronic infectious disease reporting. This is one of those examples where we're moving away from paper. Instead of having a situation where, up until just a few years ago, but in some communities it's still the case, if we get a report from a laboratory that someone in a small town has TB, the way that we deal with that in the old-fashioned way is call the local health officer and hope that the local health officer is at the phone and that they'll answer, because maybe they're out doing a community sanitation related task or fax. But what the local health officers will just say, we're stretched. We can't be waiting by the phone or the fax. So sometimes we've had delays in terms of our ability to get the word out about infectious disease because our systems just weren't robust enough. The MAVEN system that now exists in all of the communities where there's colors on the map now does real-time electronic reporting of infectious diseases on a computer screen that can be accessed easily by a health officer, and allows for coordination of a response across communities. So if you had that patient with positive TB test who lived in one community but went home and went to work in another community, or had a child in the neighboring community that she brought in for daycare, and you needed to do things in each of those communities to protect the public, interview people who might have been exposed, now it's done online, and there's real efficient communication between the health officers about who did you talk to, okay, I just found out that there's someone else you should talk to. So it's a wonderful new tool that is helping us to do better public health. And then this is my final slide. The final slide is a thank you to any of you who've been involved in emergency preparedness. If I would have talked to you about what's the role of healthcare providers and public health officials in emergency preparedness on September 10th, 2001, most people would have said, well, that sounds like something the police and the fire do. And so what we've done is really come a long way over the last decade, because now we recognize the critical role that public health and clinicians play in emergency preparedness. So those are just some things in the last year or so where we've got, tornadoes going down this main street in Springfield and Mendon, where people had to live in shelters for long periods of time without having the time to get their medications before they left home. And so who went in and screened them and determined who needed what medications and arranged with the pharmacy that they should be taking them appropriately. It was the Medical Reserve Corps and the public health officials. When people were in those shelters grieving perhaps the pet that died, or not sure if a relative was okay, and there was anxiety and tension and depression, it was the healthcare professionals who worked in those shelters to address those needs. Hurricane, I'll give you one story about the hurricane. When the Hurricane Irene came, we didn't know how bad it was going to be. It wasn't as bad as we feared, but it looked like it might be. Right before it hit, the emergency people were saying, we need to shut down in the greater Boston area the MBTA. Buses shouldn't be running and trains shouldn't be running because that would be dangerous. The transportation people made that decision. And when they talked to the emergency preparedness people that included health folks, they said, well, have you talked to the hospitals about this? Because the hospitals need to have healthcare personnel on a 24-hour basis, and if you're making that decision with only a few hours' notice, they can't get their workers home, and they can't get the other workers in, and there has to be special arrangements with hospitals. So we could do, within an hour, we had a telephone call with every hospital in the region, with the emergency preparedness person from every hospital on the line, saying, here's how we can handle that. And the decision was made to keep the buses and trains running one additional hour. The hospital said, if you keep that 1 hour going, we'll figure out a way to get our people in and to get the other people who need to get home, and we won't lose any, we won't be putting the patients at risk. And so the system worked, and it worked quickly. But you couldn't have pulled that together if you didn't have an emergency preparedness person at the hospital who could figure out the transportation, a contact person. It's very important that we retain those. And you may remember a year ago, just when there was the earthquake and the tsunami in Japan, and for at least a week, we were worried about radiation poisoning in the air, the water, and the food supply. This was like the story anybody wanted to talk about. And we had to become radiation experts. I had to answer questions like, if my dog drinks rainwater, is it safe? Is it safe for, what do I need to do with my dog? And I would call CDC and say, what about trace elements of radiation? Is the dog okay? But the public wanted to know. I mean, that's an example where, and they knew health people, public health people were the people to turn to. So we need to retain that skill. And not to end on a downside, but this money is on the chopping block in Congress now. People in Congress are telling me, didn't we buy all that stuff already? Wasn't this about buying trucks and boats, and now we're okay? We're maintaining, no. Health people, we got expertise, and we bought the ability to show up when an emergency occurs. So we need to collectively work to protect that. So all that to say, challenging times, real opportunities, great work. And with that, I think I'll end the formal presentation and open things up for conversation. Thanks. And this is Tommy. Tommy is Oprah for this conversation. Can you raise your hand?
In the white.
Yeah, very good. So anybody would like to comment or ask a question or share an experience? Great.
Thank you. That's loud. We want to applaud your work, Commissioner. You have been just such a health preventative promoter in our state. We really appreciate it. And there's many people that are here today that represent the Mass in Motion, Fall River, the Mass in Motion, New Bedford, and then we do have a regional coalition, Our Voices for a Healthy South Coast. So we really appreciate what you've done for us. And I would just encourage folks, just one quick example story.
Yeah.
Because of your work in the Department of Transportation, which we really appreciate, the whole complete street with finally looking at pedestrians and cyclists. Quick story. And I encourage all the folks that are here to be aware of what's going on in your community where you live, because we need to follow what's going on in our communities, because we had a situation happen in the community that I live in, to be not named, where at a public hearing they were going to chop the sidewalks, the crosswalks, and the bike routes on a state route. So we had to be present at that meeting in order to make sure that our town planner and select people and zoning people said, well, there are no bicyclists. And I'm like, there's no bicyclists because it's not safe. They're going to get killed. So that, so I encourage folks to, keep aware of what's going on, and we need to show up and support what you're doing at the state level in our local communities.
Thanks. That's great. What happened? Did they change their mind? Or?
Yes.
Oh, good.
I was waving my arm. Are we going to have public comment? So,
Well, that's
yeah.
a great story.
Yeah.
Thank you.
So, Thank you. That's just one. Okay, where's it going next, folks?
Thank you. At the last minute, I was asked to speak on behalf of the Greater New Bedford Allies for Health and Wellness.
Great.
And so I'm kind of winging it here. First of all, we do want to thank you. You know we are one of the Chenals, and you know the Chenals are working as inter-Chenals now. There's 6 of us down here.
That's great.
And we're really excited about that. However, there are a few Chenals that are going to be in serious financial trouble within the next year. And I think you know which ones they are. In our case, we've been motoring right along with wonderful DONs, and 2 of the DONs are going to, it's over, June. And we have another one, which is the community health worker. Thank you very much. We're very excited. I think we're going to have a model program, thanks to the funding.
Thanks. Where's Kathy? Kathy O'Connor really deserves the
Thank you, Kathy. We're very excited about that. But that money's all earmarked in that project, as it should be, and we're excited. But do you have any idea what's going to happen for the communities that don't have DONs coming down the pike? Because it looks like a lot of that's drying up. A lot of the community providers are not going to be doing any serious capital improvements in the near future. And so we're just kind of wondering what's going to happen.
Yeah. You know, it's great to get the money that's attached to a big DON project, but we really don't want projects built that aren't needed, right? So that's part of what we're also looking at. We are trying to see whether or not we should be having a DON review for more types of activities, and that may expand as there's an effort to really control costs and really think about needs. So maybe new opportunities there. We're going to pay attention to how that plays itself out. That will be part of the payment reform debate too. But I think that the key thing is trying to get a solid base of funding, because I think, as you point out, it's very erratic when you don't have money, and then you have an opportunity, and but your opportunities for 3 years, and then the 4th year, the good work that's been there stops, and we've got to get a solid funding base so that good work that's being done by the Chenals is maintained and doesn't have to just go up and down like that. And I think that the key to it is finding, having a solid grant line item from either the state or the federal government. And we're doing our best to highlight that. One area that we're asking for increased funding is in prevention work. This is part of Cheryl's work. And we've gotten real progress this year, we think, in having a receptive audience in the legislature, as indicated by the fact that for the first time the legislature's formed a prevention caucus in Massachusetts. And they're holding forums where they're, for other legislators, highlighting really good efforts, including efforts that are being done by the Chenals. But I think that's the key. I think we have to get a solid base of funding, and so that there's a way to count on that. And I don't have a quick way of doing it other than really trying to build a case with the legislators that we need the money. But I think that having good examples of how it's been used helps a lot.
Well, we do. We're happy to advocate anytime you want us to.
That's great. Good. We want you. That's good.
Thank you very much, Commissioner, for a very enlightening and positive, even though there's a lot of negatives going on. Today, I'm representing the 6 community health network areas in southeastern Mass, Region 5. And in November of this past year, we planned and participated in a day-long inter-Chenal conference in which participants explored ideas about the possibility of Chenal work in the southeast region and how Chenals can support each other to realize these possibilities. The result of that conference, echoed by almost every evaluation we received, is the desire for continued opportunities to continue the work we begun that day. And to that end, we're working on our next conference, tentatively scheduled to take place in May, and we hope we can depend on your participation at that. Every member of the 6 Chenals in our region come to the table as Chenal volunteers. Many of us have positions of leadership and responsibilities in related fields, and all of us care deeply about the health and well-being of the communities we represent. I know I speak for all Chenal members in saying that we're committed to the mission of our local Chenal and the Inter-Chenal. However, all of us balance our ability to participate in Chenal with the responsibilities and time commitments of our day-to-day jobs. Technical assistance enables us to continue to create and implement advanced, high-quality initiatives at both the individual Chenal and Inter-Chenal level with minimal impact on our existing affiliations. The Inter-Chenal Conference confirmed our sense that as a region, we can be a stronger force in promoting the department's mission to direct evidence-based practices to improve primary care and preventive health services for vulnerable populations. In particular, working together as a region, we can provide a clearer message to the public as to who we are and what we want to do. We can also offer a richer offering of staff development, skill training opportunities to the hundreds of people in our communities who are already committed to the department's mission. Finally, we can make more effective use of the resources we currently have and expect to have in the future as the determination of needs process goes forward. Therefore, we encourage the Massachusetts Department of Health to continue to provide both technical assistance support and direct skill training to support our ongoing efforts. We would like to have skill training offered at the regional level for members of our community who need to be involved in a range of activities. These prevention efforts are focused on concerns including, but not limited to, substance abuse, tobacco, marijuana, alcohol, heroin, OxyContin, and prescription drugs, violence among youth and young adults, obesity and the lack of healthy activities, poor access to nutritious food, sexual health, and efforts to improve the physical environments that can encourage healthier living. We are also requesting that the department ensure that our region has both the guidance and the opportunity to design, carry out, and evaluate specific strategies that address health disparities among the populations, including minorities, immigrants, low-income individuals, individuals with disabilities, and seniors. We would envision that being provided through train-the-trainer events for neighborhood-based prevention specialists. We would also request support in helping both paid staff and community leaders in understanding the significance of specific regional indicators, such as homelessness, unemployment, rates of addiction and violence, as well as data provided by the department and other sources. We hope that the newly configured system in cooperation with DPH will find the means to continue to provide assistance to us at the regional level. If the new system does not or cannot support the Chenals, we hope that DPH will consider alternatives that will allow for some level of ongoing technical assistance support. While some work can be maintained absence of support, we feel strongly that technical assistance at the regional level can continue to maximize our efforts in a manner that it would not be able to otherwise. We think and expect you will find that Chenals from other statewide regions, although different from one another, would benefit in a similar way. This will result in a robust and productive statewide system that can continue the good work that we've become known for in the communities we represent across the state. Greater Brockton Community Health Network, South Shore Community Partners in Prevention, Greater Taunton Health and Human Services Coalition, Fall River Partners for a Healthier Community, New Bedford Allies for Health and Wellness, and Cape and Island Communities Health Network Alliance. Thank you.
Wow, thank you. Well, thanks for that. I do think while other Chanas around the state would agree with probably everything you said there, I think you all are really on the wave, I'd say, of cooperation. And so just to come together and craft that and have that level of interaction, that's great.
And we'd love to be able to continue to offer that support across the state as the model and working in cooperation with you.
Good, thank you.
Maybe you should attend one of our Inter-Chenal meetings.
I have been known to attend when invited, so
Open invitation.
thank you. I don't want you to think I'm 110 years old, but I can remember when the idea for the Chanas was just a twinkle in Commissioner David Mulligan's eye, so I feel like it's been nice to see that it's lasted for decades and that good work's being done. So thanks. Yeah.
To formally continue what Wendy just very nicely expressed for the Southeast Inter-Chenal. we would like to suggest that one representative from each Chenal region be designated to work in cooperation with you, Commissioner, and with the Department of Public Health to explore technical assistant issues moving forward. Would this be possible?
I think so. It doesn't sound like a complicated request. I mean, it sounds like that's the total spirit of what the Chanas have been, so having that is fine, would be, right? And, you know, so we'll talk about the specifics, but between Kathy, Jeff, me, you know, that's a very easy and helpful request, so thank you. Yes.
I'm the coordinator for New Bedford Mass in Motion, and I speak for New Bedford, but also for the Greater New Bedford Allies for Health and Wellness, and it's great to see our Voices for Health and South Coast partners as well. So all our friends are here today, and we are here to tell you that things are happening down here on the South Coast. I think that we've gotten your attention in recent months.
That's safe to say.
And we're very grateful for that opportunity. And I need to say that it was wonderful to hear about the collaboration between, as a clinician by background, the clinical and community pieces in terms of prevention. And I just, when you talk about the gray area and so on, I just think that we are seeing it, and we use a term here, and Ron O'Connor will certainly attest to this, we use this term convergence down here.
Yeah.
And we just see, it started maybe more with Mass in Motion, but now we're working much closer, more closely in terms of health equity. We are hoping to have an equity summit in June. We are doing more toward community health worker empowerment, as you know. And I'd just like to say that I think all this good work has not just gotten the attention, but it's brought people closer together in terms of where we're going next. In New Bedford, we have the CORD grant, which, again, I know that the obesity research has built or is going to build upon what Mass in Motion has accomplished. And I just also wanted to just mention, last week I met the Surgeon General at Northeastern, and Cheryl did a beautiful job presenting Mass in Motion. It was just a most wonderful thing to see the lineup of Senator Bigby and the Governor Patrick and the Surgeon General, and above them was a slide that showed the International Walk to School Day in New Bedford with all the kids and the New Bedford Mass in Motion banner and the rain and the umbrellas. But it was just a wonderful feeling to know that, that the word is spreading across the country.
The Surgeon General told me that this, for those of you who don't know, the Surgeon General really, I don't think she makes visits like this very often, but she came and spent 3 days full-time with us on prevention activities, and she was great. She said, I'll do anything. And so we ended up doing, in addition to the event that you were talking about, which was a big event with the governor, and we were talking about prevention, she also did a Mass in Motion event with us later in the week, where we highlighted another community that was part of the Mass in Motion effort. But she left and is saying that this is the best work I've seen in the country. That she really felt like this is what the federal government wanted to be supporting, that this was the kind of work that was going to not only be better in terms of the most important thing, which is improving people's health, but better in terms of reducing healthcare costs in the best possible way by keeping people healthier. And she was, by the time she left, she was, just singing our praises. It was very nice to hear. We're in a situation now where a third of our kids in elementary school are overweight. It's a third. And they come in overweight. 31% of first graders are overweight. 20 years ago, it would have been single digits. Now it's 31%. So, we've got to figure this out in a way that's going to have an impact on large scale. We can't just be, having kids that have access to a really wonderful program here, but it's only 20 kids, and then, we've got to figure out how to reach whole communities. So that's great. Thank you. Oh,
Hi, Commissioner.
Beverly Costa Ciavola, Cape Cod Neighborhood Support Coalition, which is a community connections coalition, and Chinat 27.
Great.
And I just wanted to talk a little bit about suicide prevention
Okay.
work because, as you know, the state did not get the Garrett Lee Smith awards again this year. And particularly on the Cape, I think we've worked exceptionally hard to put together a really comprehensive suicide prevention program. Specifically for youth, but which has gone across the ages. And we continue, and 3 years is not enough time to do any, we have made a good start, but it is just one tiny little piece in a 5,000-piece puzzle. And in particular, in the town of Falmouth, we had almost a dozen suicides in 1 year last year. Mostly middle-aged men, but also a couple of youth. We also know through just word of mouth that we've had considerable amount of attempts by youth, and we've had some completed suicides. So I just want to urge you to somehow squeeze some suicide prevention money out. The coalition does a wonderful job, the state coalition, and we stay very engaged with them. And as you know, we have our own local coalition, the Cape and Islands Suicide Prevention Coalition. But really, the bulk of the work has been done by More Aware and the Youth Suicide Project out of the Community Health Center. And of course, Archana, having written that grant, has a really important vested interest in that. So I just hope that somehow, some way, we can get some kind of suicide prevention money because, Massachusetts may be one of the lower states, but we have these huge pockets, and the Cape and Islands is one of them, and we have too many suicides going on. Thank you.
I agree with you. I think that it's really entirely about our making the case for funding, because we really need our line item to be able to do that, and I think it's critically important. And so I want to praise the work that's being done on the Cape and on the islands in terms of the suicide prevention. Because one of the things that we've learned about suicide is that when there are geographic reasons that communities or cities and towns are insular, that then you can really have this sort of copycat series of suicides.
We saw that at Nantucket.
We saw that in Nantucket, and I think the Cape is like that too. I think the bridge and the physical isolation creates that kind of sense too. That where specialized efforts are necessary in order to reduce the risk. And so, thank you for the work that you've done on that. You definitely deserve to have continued funding. Thanks.
I hope we get it.
Me too.
Thank you.
Me too. So with that, let me just say thank you to all of you. Thank you for the work that you're doing.